it's estimated that like a 6-month seizure freedom can be achieved in 8% of patients with VNS, 18% of patients with DBS, and about 28% of patients with RMS.
Fellow Homo sapiens, welcome back to Epilepsy Sparks Insights. Now, we have heaps of neuromodulation devices on the market to treat the epilepsies right now, but keeping up with developments is pretty hard work. So I am really happy to introduce to you this week rising star neurologist and epileptologist Anna Bochenek, who gives us the professional lowdown on vagus nerve stimulation, deep brain stimulation, and responsive neurostimulation, some statistics, plus new ideas and devices that are kind of in the pipeline or being researched right now as well. Please don't forget to like, comment, and subscribe to the channel, because your comment and your like will help spread awareness and understanding of the epilepsies around the world. And now on to that star of the week, Anna Bochenek.
Hi, Torie. Thanks for having me. My name is Anna Bochenek. I'm an adult neurologist and epileptologist. I work at a Center for Neurology, Epilepsy, and Psychiatry, Neurosphera in Warsaw, Poland.
And what got you into this specifically? And why adults rather than children?
Children are, I think, too difficult emotionally for me, so I chose adults. And specifically epilepsy. Well, I was kind of torn between movement disorders and epilepsy, because I consider that like the meat of neurology. And both of them actually have a lot of neurostimulation, neuromodulation devices as a treatment option. So that's something that drew me into that. And in the end, I chose epilepsy.
So what's the difference between, for people who aren't aware, and I get confused too, between neurostimulation and neuromodulation?
It's a difference in naming mostly. So there's used to, we call them neurostimulation device, because you use electric stimulation to affect the brain, right? But the more we've learned about this method, the more we found that it's not just the stimulation that happens in the moment. It's more than that. It's a neuromodulation effect. So something that's a bit of like a disease modifying effect of those devices on epilepsy. There's this like whole area of electroceuticals. So there are different names we can use for those devices. Like in contrast to pharmaceuticals, so drugs and medications, you have electroceuticals now. So devices that use electric stimulation to affect body. So you have pacemakers, cochlear implants, things like that, right? And neurostimulation and epilepsy is the same idea. So using electric stimulation to affect the brain with the aim to reduce seizures. And you do that through this like modulation process that takes time. So I know you've talked recently with Dr. Tomic about epilepsy surgery. So I think that's managing expectation as well. So I think that's one of the things that's important to mention with the whole neuromodulation idea versus brain surgery. There's a big difference here. One is considered palliative treatment. So we don't aim for seizure freedom with neuromodulation. Two, whereas brain surgery gives you like immediate results, with neuromodulation, the effects are much slower. It's a long game we play. So the effects are gonna improve over the course of few years. So I think that's something important to mention. And that happens due to this modulation effect. So we don't fully know how it works, but it appears to have effect on both receptors, synapses, gene expression, neuronal growth, neurotransmitters. So there's many things how it happens, but it takes time. So it's like neuroplasticity, neuromodulation, process that takes quite some time. So we prefer to use neuromodulation name right now because it kind of underscores this mechanism of action behind.
And what are the different types then of neurostimulation through neuromodulation?
Okay, so currently we have 3 devices that are approved for epilepsy treatment. So we have VNS, vagus nerve stimulation, DBS, deep brain stimulation, and RNS, responsive neurostimulation. And each one has its own like advantages, disadvantages. There are quite few similarities between them, but there are also differences. So when it comes to VNS, I know you had an episode on that before. So it's the one we've used the longest for more than 25 years now. There's probably more than 100,000 patients implanted with this device worldwide. And each of those devices is built in you could say, similar way. So you have some components that each of them needs to have. So you have a pulse generator, which is a device that is implanted either under skin on your chest, under your collarbone, or in case of RNS, so the responsive neurostimulation, it's implanted under your scalp, within the skull.
You say within the skull, are you talking about like on top of the brain rather than within the bone?
No, it's within the bone.
Really?
Yeah, that's why it's approved only for adults, because you need to have a certain skull thickness, so certain bone thickness, to be able to attach that device.
Gosh, how embarrassing! I didn't know that. That's like, wow. That's interesting. I want to see a video on that. Sorry, carry on.
So that's the generator. Then you have electrodes. And in case of VNS, the electrode is connected to your vagus nerve, so in your neck. And in case of DBS and RNS, there are electrodes that are implanted in your brain. And then you have like the programming system, so something that your doctor is using to program your device. So that's how it's built. When it comes to differences between the devices, there are quite a few. And we try to pick the device that's best for a specific patient, right? So there are some things we need to consider. If you have a patient who wants to avoid invasive brain surgery, so implanting the electrodes into your brain, then you're left with VNS, so vagus nerve stimulation, right? If you have a patient who wants to avoid pre-surgical evaluation, which is required for RNS, so the responsive neurostimulation, you're going to be left with either VNS or DBS. The RNS, so the responsive neurostimulation, is different in this sense, and it requires this pre-surgical workup because you need to have a seizure focus localized, because you need to know where you want to implant the electrodes, right? And then that device relies on like a real-time EEG data and delivers responsive stimulation to patients' EEG recording. What's cool about it, it also allows long-term recording, right? So you have like a EEG recording going on constantly in your brain, which might be important for some patients, especially patients with bitemporal epilepsies. So you've probably heard about that, read about that. Can be quite tricky how to treat that, right? Whether to operate, when to operate. So if we have a patient like that and we have this access to long-term recording, then we can actually see whether this one of those temporal lobes is actually dominant, more active. It's the seizure focus. And then it might allow patients to go through surgery in the end, which is like a curative treatment.
Well, fingers crossed, curative. Not always, right?
Yeah, that's the thing. In case of brain surgery, if you have a well-selected patient, your chance of seizure freedom can be between 50 to 80%, let's say, depending on a patient, depending on the type of surgery, of course. With neuromodulation, those numbers are lower. So you can achieve some longer periods of seizure freedom. It's estimated that like a 6-month seizure freedom can be achieved in 8% of patients with VNS, 18% of patients with DBS, and about 28% of patients with RNS. So it seems much lower than the surgery. But if we look at anti-seizure medications in drug-resistant patients, so if you're on your 3rd, 4th, and subsequent medications, your chance of seizure freedom on each of those is about like 5%. You can have seizure reduction, but your chance of for seizure freedom is low.
Or even less, right? I mean, I've heard other numbers that
even less. Yeah. So some studies say between 4%, like some it's less than 5%. Yeah. So those 8%, 28%, it's still much higher number. So it's something that's definitely worth considering as a treatment option. When it comes to further differences. So, like I said, it's a long game, right? So unfortunately, we need to educate our patients and manage their expectations. And that's very important because I've had some patients that were not pleased with the results because they didn't have the education beforehand, what to expect, right? So in general, the seizure reduction is quite similar between different methods. DBS and RNS seem to be a little bit more effective, but it might be negligible. So in the first year of your treatment, you can expect to have about 40% of seizure reduction.
Mm-hmm.
And that number goes up in the year 5 or 7, up to 75%.
So it's like as your brain almost learns to make the changes incurred by these treatments.
So that's the plasticity. That's the plasticity and the changes that are going on there, and that's the disease modifying effect that we see. We don't have, unfortunately, any biomarkers, anything we can look for in the patient that's going to tell us, oh, you're going to respond better to this, or you're going to be non-responder. Because there are some people that are non-responders. About 1/3 of patients will not respond to neuromodulation, and there's no way for us to predict that this is what's going to happen. There are many studies going on to find those biomarkers, so to improve the whole process of picking the right neuromodulation for a specific patient. So a VNS procedure is considered quite simple. It takes about 1 to 2 hours. DBS and RNS are more invasive, so the procedure is going to be longer. It's going to be on average more than 4 hours. Most devices have non-rechargeable batteries. So if you get a device like that, you need to know that in 3 to 5 years, you're going to have your battery replaced, depending on your settings. There are some rechargeable devices with DBS. So then you have to charge your battery every week or 2 weeks for 30 to 60 minutes. But you still need to have your battery replaced, but in 9 to 15 years instead of 3 to 5 years. There are some cool new options as well. So some non-invasive devices that are currently under research. There's transcranial magnetic stimulation, which is already approved for drug-resistant depression. So it's a device that's just placed against your scalp, and it sends magnetic pulses. And the session usually lasts between 30 to 60 minutes. You do it 5 days a week over the course of 4 to 6 weeks. So this is initial therapy. And then you have a more of a maintenance stage when that's less frequent. It looks promising for depression for now. There are no specific recommendation for epilepsy just yet, but it might be something that we might use in the future. And VNS also has variation, which is a transcutaneous VNS. So you don't have to have electrode implanted. You can just place it over your skin. So it stimulates one of the vagus nerve branches. It's usually around the ear, so it's an auricular branch of the vagus nerve. And you can stimulate 15 minutes a day. You can stimulate a few hours a day. But it's considered for now less potent than the traditional implantable VNS.
And what's interesting is that, well, obviously we have to manage our expectations here, but if you improve the mental health of somebody with an epilepsy, you're often indirectly, you can reduce their seizure frequency.
Yeah, because what we've talked so far is just seizure reduction, right? And seizure control. And those devices have other benefits as well. Improve mood, sometimes improve cognition. They can also decrease the risk of SUDEP, which is also quite a big thing.
Yeah.
It's more than just seizures. So let's hope that, like in the future, we're going to have better tools to pick the right device and the right type of stimulation for specific patients, so the numbers we have can go higher, and the other benefits are also going to be noticeable.
A huge thanks to Anna for providing with us so much useful information and statistics on neuromodulation device options, plus some excitement for the future. Again, if you haven't already, please don't forget to like, comment and subscribe, and we'll see you next time.